Renin-Angiotensin-Aldosterone System. In this animation, we will review the normal physiology of the renin-angiotensin-aldosterone system. We will also demonstrate how this system regulates blood pressure. Furthermore, we will highlight the effects of pharmacological agents, such as ACE inhibitors, angiotensin II receptor blockers, aldosterone inhibitors, and renin inhibitors. Here are some of the major organs affected by the renin-angiotensin-aldosterone system. The kidney is where the normal physiology of the renin-angiotensin-aldosterone system begins. Let's take a closer look. In this illustration, we see the aorta supplying blood to the renal artery, which sends blood to both the kidney and the adrenal gland. We will now zoom in on the kidney and even further to a nephron. In normal glomerular filtration, blood flows from the renal artery to the afferent arteriole. It then travels through the afferent arteriole into glomerular capillaries, where filtration occurs. Blood filtrate passes through the proximal tubule, where most of the filtered substances are reabsorbed back into circulation. However, what goes unfiltered in the blood continues on to pass through the efferent arteriole. When blood pressure decreases, the flow of blood through the renal artery, and subsequently the afferent arteriole and glomerular capillaries, decreases as well. Because there is less blood flow, the amount of substances able to be filtered, such as sodium, also decreases. Macula densa cells of the distal tubule sense this decrease in sodium and activate juxtaglomerular cells on the afferent arterioles to release renin into the circulation. Renin converts angiotensinogen, an enzyme produced in the liver, into angiotensin I. Angiotensin I then travels to the capillaries of the lungs, where it comes into contact with angiotensin-converting enzyme, or ACE. ACE converts angiotensin I into angiotensin II. Angiotensin II has two major effects that work to maintain a normal blood pressure. The first is that it causes peripheral arterioles throughout the body to constrict, including the afferent and efferent arterioles. In the kidney, angiotensin II affects efferent arterioles more than afferent arterioles. Increased constriction of the efferent arterioles relative to afferent arterioles causes an increase in glomerular pressure upstream, leading to an increase in glomerular filtration. A subsequent increase in sodium reabsorption causes blood pressure to return to normal. The second major effect of angiotensin II to help maintain a normal blood pressure occurs in the adrenal gland. Let's zoom into the adrenal gland, and even further to the zona glomerulosa layer. Here, angiotensin II binds to receptors on zona glomerulosa cells and acts through the IP3, or inositol triphosphate calcium system, to increase the production of aldosterone. Aldosterone then enters the circulation and travels to the kidney. In the kidney, it filters through the glomerulus to bind to receptors on principal cells of the collecting duct. This results in increased sodium reabsorption, which leads to an increase in blood volume and subsequently blood pressure. Increased sodium reabsorption soon normalizes the amount of sodium in the circulation and causes a decrease in renin release. Decreased renin levels result in decreased angiotensin II production. Which leads to vasodilation. This serves to balance the increase in blood pressure initially caused by angiotensin II. The effects of pharmacological agents on the renin-angiotensin-aldosterone system. These agents include ACE inhibitors, angiotensin II receptor blockers, aldosterone inhibitors, and renin inhibitors. They function in the treatment of hypertension, post-myocardial infarction, congestive heart failure, diabetic nephropathy, and chronic renal failure. Action of angiotensin-converting enzyme inhibitors. In the lung, angiotensin-converting enzyme, or ACE, is blocked by ACE inhibitors. ACE inhibitors, such as lisinopril, block ACE from converting angiotensin I to angiotensin II. By doing so, they contribute to decreased levels of circulating angiotensin II, resulting in vasodilation. Action of angiotensin II receptor blockers. Angiotensin II receptor blockers, or ARBs, such as losartan, block the action of angiotensin II by preventing it from binding to its receptors on blood vessels. This causes vasodilation and a subsequent decrease in blood pressure. Angiotensin II receptor blockers also work in the adrenal gland. There, they prevent angiotensin II from binding to receptors on zona glomerulosa cells, thus blocking IP3 release and the production of aldosterone. Action of spironolactone. Aldosterone inhibitors, such as spironolactone, inhibit the effect of aldosterone by directly competing for intracellular aldosterone receptors in collecting ducts. This prevents aldosterone binding and subsequent sodium reabsorption. Action of aliskiren. Renin inhibitors, such as aliskiren, bind to renin and prevent its conversion of angiotensinogen to angiotensin I.